spirometry, right? On spirometry. So if I send my patient for spirometry and after that I obtain this flow volume loop or flow volume curve, okay? If this green one that you can see, the green dotted line, this is a normal patient. Down the line we have inspiration. Above the line we have expiration. So this is a normal patient on the green line, okay? But if my patient is having almost normal respiration, normal inspiration, patient is having normal inspiration, but during expiration, the time taken is prolonged. So there is a prolonged expiration. This is a feature of obstructive lung disease. So this is a feature of obstructive lung disease. This is a feature of obstructive lung disease. So this image came in August examination. Okay, so please remember, if you can see a notch or prolonged expiration, it is a feature of obstructive lung disease. In obstructive lung disease, there is an obstruction in the bronchus or the bronchioles, right? And inspiration would not be a problem, but on expiration, it will take a longer time. Whereas if I see that the inspiration is decreased, okay, expiration is normal, but the inspiration is decreased. Expiration would be somewhat lesser, क्योंकि अगर अंदर कम जा रहा है तो बाहर भी कम ही आएगा, right? So if inspiration and expiration both are somewhat decreased, it is suggestive of a restrictive lung disease. It is suggestive of a restrictive lung disease. ठीक है, flow volume को रट लेना, ये exam में आ रहा है बार-बार. No issues with this, only these three. So now please tell me the differences between OLDs and RLDs. OLDs are obstructive lung diseases like COPD, bronchial asthma, okay, bronchiectasis. Whereas RLDs are restrictive lung diseases like interstitial lung disease like pneumonia, emphysema is a COPD again. So it is an obstructive lung disease. So restrictive lung disease would be interstitial lung diseases, okay, chest wall diseases. It can be something like diaphragmatic paralysis. All of that would be restrictive lung disease. Okay, no issues with this, anybody? Important. So please remember, अगर वो पूछते हैं spirometric features, ये हमेशा question में आ रहा है बार-बार. So I'm telling you. First of all, talking about FEV1. Okay, FEV1 is forced expiratory volume in the first second. So first, FEV1 would be reduced in. FEV1 is reduced in. FEV1 is reduced in. FEV1 is reduced in, and normal or high in restrictive. Next, if I talk about FEV1 by FVC ratio. So FEV1 by FVC ratio is decreased in obstructive. It is decreased in. FEV1 by FVC is decreased in, whereas normal or high in, then residual volume would be high in. Residual volume कब high होगा? When the air which is going outside is trapped in the lungs itself. ठीक है? जिसमें expiration में problem है. That is obstructive lung disease. So residual volume would be high in. Whereas it would be normal or low in. It would be low in. Normal तो बहुत rarely होता है, low ही होता है. ठीक है? Because lungs का compliance कम हो जाता है. Sorry. And if I talk about TLC now, total lung capacity, these चार parameters याद रखने तुम्हें, इसी से question बनता है. Total lung capacity, if I talk about, please tell me, total lung capacity is increased in OLD or RLD? Total lung capacity is increased. In why? So as I told you, if in obstructive lung disease the air is not able to go out, it will stay in the lungs, so residual volume increases. And if residual volume increases, total lung capacity increases. But in restrictive lung disease, the lungs are not able to expand. Compliance is gone. Therefore, the residual volume decreases, and therefore the total lung capacity decreases. No issue. Jaldi se. FEV1 is low in. FEV1 by FVC ratio is low in. Residual volume is low in. Total lung capacity is low in. No issues with that. ये table याद रखो. Now, if I talk about asthma, I need to diagnose. Definitely, I have diagnosed that it is an obstructive lung disease by this slow volume curve. I have got that red colored graph. Now, I need to differentiate whether it is a reversible obstruction or a irreversible obstruction. Reversible obstruction is seen in cases of bronchial asthma, whereas irreversible bronchoconstriction is seen in cases of bronchiectasis or emphysema. Okay, so this is how you differentiate. So please remember, you will check for FEV1, it will be low after giving which drug? Salbutamol, that is a SABA, short-acting beta-2 agonist. If the FEV1 becomes normal, okay, if the FEV1 becomes normal or more than 12%, then it is diagnostic of bronchial asthma. So investigation of choice for bronchial asthma is spirometry. Investigation of choice for bronchial asthma is okay. So how much it would be diagnostic if the FEV1 improves by more than 12%. If FEV1 improves by, अगर नहीं improve होता, that means it is an irreversible damage like emphysema or bronchiectasis. No issues with this. Sputum microscopic 3C, you remember. Now if I talk about the biopsy in cases of bronchial asthma, the biopsy in cases of bronchial asthma will show me airway remodeling. It will show me and three features of airway remodeling. First of all, now bronchial asthma is which type of hypersensitivity, guys? Type 1 hypersensitivity. Bronchial asthma is a so all A's. And anaphylaxis, asthma, allergies, atopic dermatitis, all are type 1 hypersensitivity. So mediated by which immunoglobulin? Mediated by. So allergic asthma mein IgE levels would be high. And which blood cell levels would be elevated? Eosinophils. There would be a eosinophilia. So eosinophilia is seen in which condition? Bronchial asthma. And which IG immunoglobulins are elevated? No issues with this, anybody? Now, so airway remodeling के 3 features. So here, as it is a type 1 hypersensitivity, the airway of the bronchial asthma patient is hyperreactive. एकता कपूर की serial जैसा. इतना सा कुछ हो जाए, धड़ाम धड़ाम. So that is how a dramatic airway is seen in cases of bronchial asthma. Okay? So even a smaller allergen can cause excessive mucus secretion in patients of bronchial asthma. Right? So the first, for excess mucus secretion, what is required? Goblet cell. The first feature is goblet cell hyperplasia. First feature is. Second, there would be a smooth muscle hypertrophy or atrophy. Smooth muscle hypertrophy. Smooth muscle, and basement membrane thickening. Basement membrane. So in biopsy of bronchial asthma, what is seen? Airway remodeling. What is seen? And what are the 3 features of airway remodeling? First is, second is, and third is. तो asthma या COPD से हमेशा एक क्वेश्चन आता है, हमेशा एग्जाम में रहा, ठीक है? So that is why it is important. पैथो या मेडिसिन कहीं से भी हो. Now please tell me, bronchial asthma में the most important cells would be, most important blood cells, eosinophils. Most important blood cells, most important immunoglobulin, most important cells, mast cells. In early phase, most important cells are early phases. The most important cells are, and mast cells will degranulate and release histamine. Mast cells degranulate and release, which will cause bronchoconstriction. Okay, on allergen. Okay, no issues with this. Now, in this usually IgM antibody is there on B cells. It is converted to IgE antibody. This conversion is called as class switching. Or isotype switching. For class switching or isotype switching, which interleukin is responsible? Interleukin 4. So interleukin responsible for class switching is? Interleukin responsible for class switching is? Interleukin responsible for isotype switching is? Same, interleukin 4. Interleukin responsible for activation of eosinophils? Interleukin responsible for activation of eosinophils? Interleukin responsible for activation of eosinophils? No issues with this? ये याद रखना important है, one liner से general pathology के. So now please tell me about the treatment. Treatment बता दो जल्दी. So for cases of asthma, what is the treatment? Only asthma I am saying. Prophylaxis, prevention, or asthma or maintenance. So nowadays, according to the recent update, Sabas have been withdrawn from maintenance therapy. याद रखना, ठीक है? So please remember, for prophylaxis, the drug of choice would be inhaled corticosteroid. Inhaled low dose inhaled corticosteroid. So the drug of choice for maintenance of asthma, low dose inhaled corticosteroids. Inhaled corticosteroids बोल दो. Drug of choice for maintenance of asthma, Drug of choice for maintenance of asthma, inhaled corticosteroids. Along with that, definitely we can add SABA or LABA. We can add LABA. We will add LABA, long-acting agents, right? And long-acting beta-2 agonists are formoterol or salmeterol. Long-acting beta-2 agonists are formoterol or salmeterol. Preferred one is formoterol. Preferred one is formoterol because it is faster acting. Okay? So please remember, for maintenance of asthma, so if a patient is having mild asthma, the patient will be given low dose inhaled corticosteroids along with LABAs like formoterol. No issues with this. Now if I say, the patient presents to you with acute asthma, that means a patient is presenting to you in a nocturnal episode of asthma with breathlessness now. Uska definitely symptoms did not improve on inhaled corticosteroids or LABA. Then what can be done? Acute asthma. So again, inhaled corticosteroids are given definitely, along with LABAs are also given. Along with that, definitely we will also give LABA to the patient, and the third drug which is added. The third drug which is added is LABA. And the third drug which is added is SABA, that is short-acting beta-2 agonist. For acute attacks of asthma. And short-acting beta-2 agonists are drugs like salbutamol, terbutalin-like drugs. No issues with this. If I say the drug of choice for acute severe asthma. Severe means definitely on all the three drugs also the patient is not responding. So here I will give nebulization of salbutamol, nebulization of along with IV hydrocortisone, along with, so here inhaled corticosteroids nahi denge, rather we will give it IV hydrocortisone is given. Okay? So jaldi se guys, drug of choice for bronchial asthma. Drug of choice for bronchial asthma. Drug of choice for bronchial asthma. Inhaled corticosteroids. Low dose inhaled corticosteroids. If both are to be marked, then low dose inhaled corticosteroids plus LABA. Low dose inhaled corticosteroids plus, and which LABA is preferred? Formoterol. Which LABA is preferred? Formoterol. Then if I talk about acute asthma. If I talk about acute asthma, then the drug of choice would be inhaled corticosteroids plus LABA plus LABA. One answer to be marked is LABA. One answer for acute asthma should be one answer should be, and the three drugs which are given a low dose inhaled corticosteroids, LABA and SABA. No issues with this acute asthma. But if I talk about acute severe asthma, then nebulization of and intravenous. No issues with this anybody. Okay? And if there is a respiratory arrest in the patient, imminent respiratory failure, then we will add other drugs also like LAMA. Okay? And LAMA are long-acting muscarinic agonist or antagonist. Muscarinic antagonist. Muscarinic drugs like tiotropium and tiotropium and no issue with asthma anybody sab samajh gaye. Moving further, talking about usi ka bhai again obstructive lung disease, but this time irreversible damage. For brittle asthma, we will give subcutaneous epinephrine to the patient. Subcutaneous adrenaline or epinephrine is given for brittle asthma. Okay? It is a type 2 asthma. Terbutalin is given IV and usually subcutaneous epinephrine. Drug of choice, one needs to be marked subcutaneous epinephrine. Now here, I hope you are quite aware we are talking about irreversible damage of the airways. Okay, so that is COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. There are two features. First is emphysema. And second is chronic bronchitis. Important. Okay. So if I talk about emphysema first, it is irreversible or reversible? Irreversible. Damage and dilatation of upper airways or lower airways? Lower airways. Emphysema is irreversible damage and dilatation of lower airways. Emphysema is the irreversible damage and dilatation of upper airways is called as bronchiectasis. Irreversible damage and dilatation of upper airways is called as, no issues with this. Lower airways, emphysema. Lower airways, upper airways, then ये समझ जाओगे तो symptoms और बाकी चीजें बहुत आसान हो जाती है. That is why I have also studied it that way. ठीक है, याद रखना. In emphysema, what is formed in the lungs? Usually bleps or bullae are formed. Okay, so these kind of bleps or bullae are formed. So for example, this is your respiratory bronchiole. This kind of a bleb would be formed. I hope talking about physiology is the quite important one-liner. What is the normal lining of respiratory tract? Ciliated or non-ciliated? Locus secrete होगा. The columnar or stamens? Columnar. So normal lining of respiratory tract is pseudostratified, ciliated, columnar, cavity. Normal lining of respiratory tract is pseudostratified, ciliated, columnar, cavity. This is a question. There are two types of cells in lungs, right? Type 1 and type 2 pneumocytes. Type 1 and type 2 pneumocytes. Which is responsible for exchange? Exchange के लिए type, exchange के लिए type, respiration के लिए type 1. Respiration और exchange क्या different है? Type 1. ठीक है. और surfactant production it is type 2. Surfactant production it is type 2. Repair it is type 2. Repair it is type 2. So whenever there is injury to the cell, type 2 cells will proliferate and form type 1. ठीक है, याद रखना. Type 2 cells are responsible for repair. Type 2 cells are responsible for repair. Main component of surfactant, anybody? DPPC, diphpalmitoyl phosphatidyl choline. So main component of surfactant is palmitoyl phosphatidyl choline. Final indicator of lung maturity. So ये ऑक्सीजन क्वेश्चन है, मैं सब कुछ कवर करना चाहता हूँ. I don't want to leave any. Important. If they ask you main component of surfactant, it is definitely DPPC, diphpalmitoyl phosphatidyl choline, also known as recyclate. Also known as recyclate. But if they ask you final indicator, it cannot be phosphatidyl choline. It is phosphatidyl glycerol. Final indicator of lung maturity is phosphatidyl. Final indicator of lung maturity is phosphatidyl. No issues with this, anybody? ये याद रखना हमेशा. ठीक है. So now here, and if there is deficiency of surfactant in neonate, the patient will have respiratory distress syndrome, also known as hairy membrane disease. ठीक है, premature infants में दिखता है. So now here, coming back to our topic, that is emphysema. इसके लिए मैं start हुआ था. So Weber's classification of airways if I talk about. Generation 0 is straight क्या? Generation 16 is terminal bronchioles. Generation 16 is terminal bronchioles. This is only the conducting pathway. This is only the but generation 17 is respiratory bronchioles. Generation 17 is generation 23 is alveolar. So this is the exchange pathway. This is the physiology questions आ चुके हैं, तो याद रखना ये important है. ठीक है. So usually emphysema is the damage and dilatation of respiratory bronchioles and further. ठीक है. So in respiratory bronchioles there would be these kind of bleps or bullae form, and here there would be trapping of air. So whenever the patient is expirating, there would be air trapping in these kinds of bleps or bullae. So here you can see a NCCT. Okay, here you can see a CT chest on which you can see these bleps or bullae containing air. And over here also, if I talk about the X-ray features of emphysema, guys, this is important. X-ray pulmon से आते हैं, and most of you make mistakes. ठीक है. तो इसमें कहाँ mistake होगी? Differential diagnosis. Hyperinflated lung is also seen in, along with emphysema, along with pneumothorax. Emphysema and pneumothorax. तो differentiate कैसे करते हो? तो first of all, first feature क्या दिख रहा है? Increased size of the lungs. This is called as hyperinflation. First is hyperinflation. First is, so here you can see the lung size has been increased, and as the lung size is increased, the dome of the diaphragm is flattened almost. So this is called as flat diaphragm. This is called as the flattening of diaphragm and flat diaphragm. कुछ भी बोलो. ठीक है? Important. Along with that, now how to differentiate? Definitely you can see some of the bleps over here. Okay, but ये हमेशा नहीं दिखते. So how to differentiate? So please remember, if you can see these bronchovascular markings, थोड़े जो whitish ये दिख रहा है ना, all of this whitish shade, if that is seen, it is emphysema. because the air is present inside the lungs. But if the bronchovascular markings are absent, then the case would be pneumothorax because the air is in the pleural cavity. Okay? So bronchovascular markings present. Kisme? Bronchovascular markings present. Bronchovascular markings present. Bronchovascular markings absent. Pneumothorax. Bronchovascular markings absent. No issues with this. And along with that, definitely the size of the chest would be increased. Therefore, it will be called as barrel chest. This is also called as barrel chest. No issues with this, guys. Now, please remember, emphysema is definitely damage due to tar. This tar will activate elastase enzyme, right, and which will damage the elastin fibers. So please remember, emphysema is seen in which type of patient? Smokers. The thin smokers or obese smokers. So the case will likely start with tall, thin smoker. So if they are talking about tall, thin smokers, you will think in terms of. If they are talking about tall, thin smokers, you will think in terms of. But if they are talking about obese smokers, you will think in terms of. If they are talking about obese smokers, you will think in terms of chronic bronchitis. Patients of emphysema are also called as pink puffer. Patients of emphysema are also called as. Patients of emphysema are also called as. So this pink is actually due to polycythemia in this patient. Puffer, sutta maar raha hai. ठीक है? Whereas chronic bronchitis में these are called as blue bloaters. These are called as blue bloaters. So why there is obesity in cases of chronic bronchitis? So please remember, both of the condition will present with dyspnea. Both of the patient will present with dyspnea, that is breathlessness usually. But the breathlessness in cases of emphysema is mild to moderate. But in cases of bronchiectasis, the dyspnea is very severe. Okay, it is almost grade 3 dyspnea, and therefore the patient becomes wheelchair bound. बैठा रहता है खाके, तो इसीलिए the patient becomes obese. ठीक है, इसीलिए these are called as blue bloaters. And blue why? Because in cases of emphysema, cyanosis is absent, but in cases of chronic bronchitis, cyanosis is. So cyanosis is present in. Cyanosis is present in. Cyanosis is present in chronic bronchitis. Important. Clubbing is present in. Is clubbing present in cases of COPD? नहीं. याद रखना, COPD में usually clubbing is absent, and this is the exception always they ask you. The recent question: clubbing is present in all the below given conditions except options for lung abscess, lung malignancy, bronchiectasis, and chronic bronchitis. So the exception would be chronic bronchitis or COPD. In this, clubbing is not seen. Okay, no issues with this. Now talking about emphysema, what is the investigation of choice? Anybody? Investigation of choice would be. Investigation of choice would be HRCT chest. And what is the treatment? Treatment in cases of emphysema would be. Treatment in cases of emphysema. So definitely oxygen supplementation is required for these patients because the patient will have dyspnea. But we need to remove the bullae as well, right? So we can perform a surgery known as video-assisted thoracoscopic surgery, where we will remove the bulla. That is called as bullectomy. That is called as bullectomy. Whereas if I ask you the treatment of choice, for the treatment of choice would be lung transplantation. Treatment of choice would be no issues with emphysema. Anybody? Chronic bronchitis की definition पूछी गई थी. Chronic bronchitis patient along with dyspnea will present to you with which type of cough? Dry or productive? Productive cough. For how many months? For more than 3 months. For how many years? For more than 2 consecutive years. ठीक है? तो याद रखना, chronic bronchitis, the patient will present to you with productive cough. For how many months? More than 3. How many months? For how many years? 2 years in a row. ठीक है? Then the diagnosis of chronic bronchitis is made, and the patient will have grade 3 dyspnea. Usually dyspnea के है ना, आजकल classification पूछा जा रहा है in the exam. Recent examination there was classification of dyspnea which has been asked. So grade 1, when the patient is having dyspnea on climbing upstairs, that means on inclination there is dyspnea grade. Inclination पे dyspnea grade. Inclination पे dyspnea grade. Straight surface पे dyspnea grade. Straight surface पे dyspnea grade. When the patient is walking few steps and stopping, grade. When patient is taking few steps and stopping, grade. And when the patient is almost dyspneic on even dressing up or going out of house, that is grade 4. ठीक है? तो ये आजकल पूछे जा रहे हैं, पता नहीं क्यों पूछ रहे हैं, बट डिस्निया यूजुअली कॉमन प्रैक्टिस में है इसलिए। नो इश्यूज विद दिस। Chronic bronchitis में what is the treatment of choice? Anybody? Treatment of choice for chronic bronchitis would be, so antibiotics can be given definitely for prevention of any secondary bacterial infection. Okay, but the treatment of choice would be low flow oxygen. Treatment of choice would be treatment of choice for chronic bronchitis. Treatment of choice for chronic bronchitis, and it is given at 1 liters per minute. It is given at for how many hours a day? 16 hours a day. For how many hours a day? So this is important. This has been asked. Okay. So chronic bronchitis में treatment of choice is low flow oxygen. For how at what rate? 1 liters per minute. For how many hours? No issues with this. ठीक है. Type 1 respiratory failure. I discuss about respiratory failure also. ठीक है, वही पे discuss करेंगे. Now एक अच्छी सी गहरी सी सांस लो और तैयार हो जाओ for ABG, that is arterial blood gas analysis. So if a patient presents to you with COPD exacerbation, ठीक है, COPD known case है, now presenting to you in an episode of dyspnea. Okay, the first thing that you actually perform is the arterial blood gas analysis, ABG. ठीक है, you will take a sample either from radial, brachial or the femoral artery. ठीक है, and which test is done? Allen's test is performed. ठीक है, Allen's test is performed to check the patency of palmar arc. ठीक है, so this has been asked for checking patency of the palmar arc. Which test is done? Allen's test is done. Which test? Allen's test is done prior to ABG. ठीक है, no issues with this, guys. Now, if I talk about ABG analysis, the three most important things that you will look at are the pH, PCO2 values, and the bicarbonate values. अगर वो कंपेंसेटेड वाला फंडा नहीं समझ में आ रहा, ठीक है, छोड़ दोगे तो मोस्टली नहीं आता है. ठीक है, तो pH, normal pH of blood is 7.352. So normal pH of blood is normal values पता होनी चाहिए, एग्जाम में नहीं आती. PCO2 normal value is on an average 40 mm of Hg. Normal value of PCO2 is range can be 35 to 45%. ठीक है, bicarbonates normal value is 22 to 26 milli equivalents per liter. Normal value of bicarbonates is अब एक बताओ फंडा, CO2 is acidic in nature or alkaline in nature? CO2 is acidic in nature. CO2 is, so whenever CO2 will increase, there would be acidosis. There would be, bicarbonate is acidic or alkaline in nature? It is alkaline in nature. Therefore, whenever bicarbonates will increase, there would be alkalosis in the patient. ठीक है? Now, PCO2 will decide whether it is respiratory, and bicarbonates will decide whether it is metabolic. ठीक है? First funda is respiratory acidosis. ठीक है? So acidosis means the pH should be. So if the pH is less than 7.35, acidosis. If the pH is more than 7.45, alkalosis. ठीक है? तो वो 7 वाला फंडा pH स्कूल का भूल जाओ, बॉडी के pH के अकॉर्डिंग बोलेंगे. Less than 7.35, more than 7.45. If it is acidosis, pH should be less than 7.35. If it is respiratory, then PCO2 level, respiratory है तो PCO2 should be higher. Okay, so PCO2 levels would be high, but bicarbonate levels would be normal. Bicarbonate levels would be. Did I talk about compensatory yet? No, ना. So bicarbonate levels normal रहेंगे. ठीक है? तो याद रखना. Respiratory alkalosis. If I talk about respiratory alkalosis, now you tell me. If it is alkalosis, pH should be. PCO2 should be. It is respiratory. So PCO2 level. If CO2 is acidic in nature, so for alkalosis, PCO2 should. No issues with this. ठीक है? And bicarbonates again would be. ये initial stages में है. Now the body will try to compensate, right? Body हमेशा will try to maintain the homeostasis or equilibrium balance, right? So body tries to compensate. अगर respiratory component है, body will try to counteract with metabolic component. ठीक है? So in the next case, they have given that the patient is having respiratory alkalosis. So respiratory alkalosis means which should be affected, CO2 or bicarbonate? respiratory alkalosis. So which value should be abnormal? PCO2 or bicarbonate? Respiratory है तो so alkalosis है तो PCO2 should be high or low? Low. PCO2 should be low. ये फंडा समझ गए? It is respiratory alkalosis. Now body is trying to compensate. So अगर there is respiratory alkalosis, so body will try to perform metabolic acidosis. There would be a counteracting metabolic acidosis. And for metabolic acidosis, bicarbonate value should increase or they should rise? They should decrease. Why? Because bicarbonates are alkaline in nature. If bicarbonates decrease, then the patient will have metabolic acidosis. ठीक है? समझ गए? नहीं समझ गए तो अभी हाथ उठाओ जल्दी से. Time invest कर सकते जल्दी. नहीं समझो? Okay. Guys, 1 minute. The patient is having main problem क्या है? Respiratory alkalosis is the main problem. So if it is respiratory, which parameter should be abnormal? PCO2 should be abnormal. If it is alkalosis, PCO2 should be low. PCO2 should be low. So जब acidic component कम होगा, तभी तो alkalosis होगा, right? So that explains your respiratory alkalosis component. Now to counteract this, body will perform metabolic. And for metabolic acidosis, bicarbonate value should be low. Bicarbonate values will decrease because bicarbonates are alkaline in nature. तो वो जब कम होंगे तब बॉडी में क्या होगा? Bicarbonate values are low, then it will lead to Asbestos. Bicarbonate values are low, it will lead to no issues with this. So now the body is trying to compensate. Partially compensate का मतलब क्या होता है? That means the pH is still not normal. Compensation क्यों होता है? उसको body को भाड़ में जाए. It doesn't care about PCO2 or bicarbonate level. It actually cares about the pH of the body. pH should be maintained within normal. ठीक है? So for maintenance of pH, it causes this. For partially compensated means bicarbonate values are decreasing, but they are not yet attained a higher value or fully compensation has not occurred. So therefore, alkalosis है तो pH would be more than 7.45. जब fully compensated बताऊंगा तो और difference समझ में आ जाएगा. अभी याद रखो. ठीक है? No issues. Alkalosis है तो pH is more than 7.45 और partially compensated है समझ pH अब तक normalize नहीं हुआ. ठीक है? So please remember, if arrows are in the same direction, that means compensation is started. If arrows are in the opposite direction or one of the component is normal, that means compensation अभी तक start नहीं हुआ. If I talk about metabolic alkalosis, नाम से easy है, alkalosis, so pH should be more than alkalosis, so pH should be metabolic है, so which parameter should be abnormal? SCO3. So SCO3 alkalosis के लिए should be high. Alkalosis के लिए bicarbonate should be higher. और कोई compensation नहीं है तो PCO2 is normal. Metabolic acidosis. Acidosis means pH less than. Acidosis मतलब pH is. Acidosis means pH is. Metabolic मतलब which parameter is affected? Bicarbonate. और acidosis के लिए bicarbonate value should be. And कोई compensation नहीं है तो PCO2 normal. Now fully compensated में जब आओ, first I talk about the main pathology. क्या है? Metabolic acidosis. Acidosis of pH is less than 7.35. Metabolic है मतलब bicarbonate. Low या high? Low bicarbonate should be there. ठीक है? Now what do I mean by fully compensated? That means the pH has been normalized. So here mostly the pH is 7.3. And why the pH has been normalized? Because to counteract this metabolic acidosis, the body has started performing respiratory alkalosis. So main pathology क्या है? Metabolic acidosis. To counteract body is performing respiratory alkalosis. And for respiratory alkalosis, PCO2 value should be low. And therefore the pH is maintained at 7.3. That is normal pH. ठीक है? So जल्दी से, it is important guys. अभी चलो मैं एग्जांपल देता हूं, ऐसे ज्यादा अच्छे से समझना है. pH is 7.3, PCO2 value is 80 FMGForFMGE, bicarbonate values are normal. pH is 7.3, bicarbonate are 80 FMGForFMGE, bicarbonate are normal. pH 7.3 मतलब acidosis. PCO2 is 80, more than that means it is a respiratory asthma. Next case, pH is 7.5, ठीक है, pH is 7.5, PCO2 levels at 12 mm of Hg, bicarbonates are not. pH 7.2 बोला, sorry 7.5 बोला, that means it is alkalosis. PCO2 12 है, that means it is respiratory alkalosis. No issues with that. Next, pH 7.3. Already बता रहा हूँ, pH 7.3 अगर है, ठीक है, so please remember if the pH is 7.3 guys, ठीक है, PCO2 values are normal, but bicarbonate values are 12 milliequivalent. Metabolic alkalosis. Next condition, pH 7.5. pH 7.5. Bicarbonate values are 50 mm of H. Sorry, 50 milliequivalent. PCO2 is normal. pH 7.5. Bicarbonate 50. PCO2 is normal. Metabolic alkalosis. No issues with this. ये सब पढ़ने तो समझ में आ गए. अगर the patient is having respiratory alkalosis, but the pH is still more, that is suggests your partial compensation. That is suggests your, if the patient is having metabolic acidosis, but the pH is normalized, that is suggests your fully compensated metabolic acidosis. No issues with this. अगर वो एक और फंडा है, एक बार पूछा गया था क्वेश्चन, क्या हुआ? Okay. I'm explaining. Wait. So please remember, guys, if the pH is 7.3, so please remember how to decide whether it is respiratory or metabolic. The parameter which goes in favor of pH, that would be important. Okay, the parameter which goes in favor of pH means if pH is acidic, PCO2 is also acidic. That means it is respiratory. If pH is alkaline, bicarbonate is also alkaline. That means it is metabolic. Okay, so whatever goes in favor of pH, that would be your answer. pH 7.3. PCO2 values 60 mm of Hg and bicarbonate 12 mm of Hg. What should be answer? So 7.3, that means it is acidosis. PCO2 is high, that means it is respiratory. Bicarbonates are low, that means it is metabolic. That means it is both respiratory as well as metabolic. Sorry, it is both respiratory as well as metabolic acidosis. ये एक बार क्वेश्चन आ चुका है. No issues with this, guys. Okay, done, understood. ठीक है. Now please tell me what is the treatment of choice for metabolic acidosis. Treatment of choice for metabolic acidosis. It is soda bicarb. It is soda bicarbonate. ठीक है. So treatment of choice for metabolic acidosis. Treatment of choice for metabolic acidosis. Treatment of choice for metabolic alkalosis. Treatment of choice for metabolic alkalosis. Ammonium chloride. Treatment of choice for metabolic alkalosis. Treatment of choice for metabolic alkalosis. Ammonium chloride is acidic in nature. ठीक है, it forms HCl. Therefore, it is given. Then ये question बार-बार आया है, 2-3 बार आ चुका है. COPD patient coming to you in exacerbation. ठीक है? So definitely he is having features of respiratory failure. Now the patient is presenting to you with respiratory acidosis. What should be your treatment? What should be your treatment? Whether it is respiratory acidosis or respiratory alkalosis, usually, definitely we will try to perform a non-invasive ventilation. First line would be a non-invasive ventilation. If it is acidosis, I will explain it to you. I will try to increase the respiratory rate, so CO2 will be washed out of the body. Okay? And if it is respiratory alkalosis, then I will give low flow oxygen to the patient. Okay? याद रख लो, it is non-invasive ventilation या endotracheal intubation. Either non-invasive ventilation or endotracheal intubation. So COPD का patient, if is coming to you with respiratory acidosis या alkalosis, answer should be either non-invasive ventilation or endotracheal intubation. क्या करना है तुम्हें? Supply तो देना oxygen का. So that should be done. I'll explain when we need to do that. So patient of COPD presents in the emergency room with exacerbation of dyspnea. ABG shows pH 7.2, PCO2 70 mm of Hg, PO2 45 mm of Hg, bicarbonate 36. अब तुम बताओगे मुझे, pH is 7.2, so it is acidosis. It is acidosis. PCO2 is 70. That means it is respiratory acidosis. It is respiratory acidosis. No issues that PO2 would be decreased definitely if the patient is having dyspnea. Partial pressure of oxygen, which is normally 60 to 100 mm of Hg, would be decreased, and it is seen in this case. Bicarbonates are 36. Means there is metabolic alkalosis. There is metabolic. So if there is respiratory acidosis and metabolic alkalosis together, this is called as compensation. This is called as compensation. But pH is still low. So is it full compensation or partial compensation? So the diagnosis is partially compensated respiratory. समझ गए अभी? You solved it by yourself. No issues with this now. So please remember, guys. Here I am talking about a COPD patient. They are asking about type of respiratory failure. So if I talk about 4 types of respiratory failure, jaldi se. So type 4 respiratory failure, anybody is seen in cases of type 4 respiratory failure is seen in cases of shock. That means due to hypoperfusion of the respiratory muscles, the muscles are not able to work properly. Okay? So in cases of any type of shock, the patient will have which type of respiratory failure? Type 4. And here the treatment of choice would be intubation plus intermittent positive pressure ventilation, IPPV. Okay? So treatment of choice for type 4 respiratory failure, intubation plus treatment of choice for type 4 respiratory failure, type 3 respiratory failure. I had a patient who underwent a major surgery and now presents with dyspnea. On X-ray, the lung has been collapsed. So the cause for type 3 respiratory failure is post-op atelectasis. The type 3 respiratory failure is due to post-op. What is the treatment of choice over here? Supplemental oxygen. What will we give? Along with chest, physiotherapy. Along with chest. What is the treatment of choice for type 3 respiratory failure? Supplemental oxygen plus chest, physiotherapy. No issues still here. Now talking about the most 2 important ones. Either it can be type 1 respiratory failure or type 2 respiratory failure. How to differentiate? Please remember, both of them are respiratory failure. So PO2 levels would be low. PO2 levels would be low in both of them, right? Because there would be hypoxemia. If I talk about PCO2 levels, this is important, guys. Please remember, PCO2 levels in type 1 respiratory failure would be normal. They would be either normal or they can be even decreased. Okay, they can be either normal or it can be decreased. Important. But in type please remember, in type 1 respiratory failure, the patient will have hyperventilation. The respiratory rate will increase, and due to that, the carbon dioxide is washed out of the body. Okay? Therefore, the PCO2 level is normal or decreased. Whereas in type 2 respiratory failure, the PCO2 levels here, the patient is hypoventilating, respiratory rate is low, as in cases of COPD patients. Respiratory rate is low, and therefore there would be accumulation of carbon dioxide inside the body. Therefore, the PCO2 levels would be high. Okay? So, jaldi se, PO2 levels are low in cases of type 1 as well as type 2. PCO2 is normal in, but PCO2 is high in. No issues with this. यही question यहीं पे खेलते हैं. COPD patients में usually we can have type 1 as well as type 2 respiratory failure. How to remember? Please remember, we have the mnemonic ASAP. ठीक है? अब तुम लिख लो full form, इधर जगह नहीं मुझे. So the examples of type 1 respiratory failure are ASAP. A goes for ARDS, acute respiratory distress syndrome. A for S for which type of pneumothorax? Spontaneous pneumothorax. S for. So please remember, spontaneous pneumothorax means a patient of emphysema suddenly turned blue. Usually emphysema patients are not blue. They suddenly turn blue. It is due to rupture of a bulla which has caused spontaneous pneumothorax in the patient. Okay? So spontaneous pneumothorax में which type of respiratory failure? Then next A usually goes for acute asthma. A for acute, and P for pneumothorax तो हो गया S से. एम्फाइसीमा याद रख सकते हो, बट यूजुअली एम्फाइसीमा याद नहीं रहता है. क्या 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 emphysema, pan-acinar emphysema याद रख लो. So please remember A for ARDS, A for S for third, second A for and P for pan-acinar emphysema याद रख लो. ठीक है. If I talk about type 2 respiratory failure, so spontaneous pneumothorax is causing type 1. So spontaneous pneumothorax is causing type 1. So tension pneumothorax will cause type. Tension pneumothorax causes type. Acute asthma causes type 1. Acute asthma causes type. So status asthmaticus will cause type. Status asthmaticus causes type. And third is diaphragmatic paralysis. Third is diaphragmatic paralysis. And the last one is chronic bronchitis. So emphysema में type 1, but chronic bronchitis में type, spontaneous pneumothorax में type, tension pneumothorax में type, respiratory paralysis or diaphragmatic paralysis type 2, because there will be accumulation of CO2 in the patient. No issues with this. Treatment अगर वो पूछे, definitely both of them we will give what? Ventilation, either non-invasive ventilation or endotracheal tube plus IPPV. Now वो क्या खेल गए? They asked you, a patient is already ventilated of COPD. Now what should be increased in this patient? Okay, the patient is suffering from respiratory acidosis. Now to overcome this respiratory acidosis, and he is suffering from type 2 respiratory failure, what we will increase? Which parameter should be increased? Which parameter should be increased? Right, we will increase the respiratory rate. So if we will increase respiratory rate and cause hyperventilation, the patient will need to wash out of carbon dioxide. So please remember, which ventilation parameter is increased in type 2 respiratory failure? अगर नहीं भरोसा तो दिसंबर का क्वेश्चन नहीं है, ठीक है, मेडिसिन का याद रखिएगा. Whereas in type 1 respiratory failure, which parameters can be increased? We will increase oxygen delivery should be increased now, so we will increase FiO2. We will increase, or the second parameter we can increase is PEEP. The second parameter which can be increased is PEEP, positive end expiratory pressure. That will keep the alveoli open, and if alveoli are open for more time, oxygenation would be better. ठीक है, तो याद रखना, in cases of type 1 respiratory failure, what should be increased? FiO2 and PEEP. But in type 2 respiratory failure, what should be increased? ठीक है, no issues with this. फंडा याद रख लेना, टाइप 1 में there is hyperventilation, टाइप 2 में there is hypoventilation. Okay, उसी से सबको समझ में आ जाएगा. Now important, they have talking about ARDS. ARDS में क्या मार्क करोगे? टाइप 1 and टाइप 2? टाइप 2 नाम. ठीक है, अगर patient is coming to an acute episode, initial stages में the patient has respiratory alkalosis and there would be type 1 respiratory failure. But in later stages of ARDS, the patient will have type 2 respiratory failure. Later stages of ARDS, patient has type 2 respiratory failure. पहले तो hyperventilation होगा, but then there will be respiratory muscle fatigue and there will be hypoventilation. No issues with this. नहीं समझ में आ रहा तो एक दो बार देख लेना वीडियो. उससे भी नहीं समझ में आ रहा तो next. An osteoporotic female sustained a vertebral fracture and was advised bed rest. Now she complains of respiratory distress. X-rays given, diagnosis is osteoporotic female sustained vertebral fracture. She was advised bed rest. Bed rest मतलब, so in cases of vertebral fracture, the patient will need bed rest for almost 3 to 6 months. So here the patient will have prolonged immobilization. Along with that, sometimes they can also give you history of DVT in the patient, that is deep venous thrombosis. Or maybe history of, which is the most common, hereditary coagulopathy, Leiden mutation. They can give you history of factor 5 Leiden mutation. ठीक है, important. Okay, so usually these history are given, and then they say the patient has prolonged immobilization. Maybe it was a case of prolonged bed rest, or the patient was taking a long flight from New York to New Delhi. ठीक है, such kind of a case is given. So the patient is more likely to develop. The thrombus would dislodge from the deep soleal veins of legs and go and block the pulmonary vessels. So the diagnosis in this condition would be pulmonary embolism. If the patient is experiencing sudden respiratory distress, it is usually a massive pulmonary embolism. It is usually a massive pulmonary embolism. And on massive pulmonary embolism, I can see three most important X-ray findings. Blood flow, अगर X-ray नहीं समझ में आ रहा, first I can see a triangular or a wedge-shaped opacity on X-ray. This triangular or wedge-shaped opacity is called as which sign? Hampton-Hump sign. Which sign? Which sign? So triangular opacity is called as whereas this dilated right descending pulmonary artery, it is called as Palla sign. This is called as the second sign is, and third, here you can see decreased blood supply to some parts of the lung, that is focal oligemia. This is called as the Westermarck sign. So three chest X-ray findings in patient of massive pulmonary embolism. First is Hampton-Hump. First is second, dilated right descending pulmonary artery. And third, focal oligemia is Westermarck sign. Now, in cases of massive pulmonary embolism, the patient can also show me some ECG features, and the ECG will show us which pattern? S1, Q3, T3 pattern. Which pattern is seen on ECG? This question has been asked. Which pattern is seen on ECG? Deep S wave in first lead, deep Q wave in third lead, and inverted T wave in third lead. Okay? So S1, Q3, T3 pattern is suggestive of massive pulmonary embolism. What is the investigation of choice? Anybody? Very good. Pulmonary angiography, definitely it is preferred, but can it be the investigation of choice because it is invasive? So better answer would be CT angiography. Better answer is, so investigation of choices. Gold standard investigation is pulmonary angiography. Gold standard investigation is pulmonary angiography is invasive, therefore it is the best or gold standard technique. But investigation of choice would be CT angiography. Now, if a case of massive pulmonary embolism comes to you, please tell me the drug of choice or treatment of choice in case of massive pulmonary embolism. We will give thrombolysis. We will do thrombolysis. Mainly, which drug is preferred? Alteplase. Which drug is preferred? It is a recombinant tissue plasminogen activator, recombinant TPA. Okay? So, massive pulmonary embolism, treatment of choice? Thrombolysis is done with? Thrombolysis तीन जगह करा जाता है जल्दी. First is massive pulmonary embolism. First is हार्ट में myocardial infarction. हार्ट में कौन से में? Stemal या unstemal? Stemal. Okay, please remember. So thrombolysis first is done in massive pulmonary embolism. Second in ST, elevated myocardial infarction, and third in cases of stroke. Stroke में कितने टाइम में करना है? Less than 4.5 hours. No issues with this. Thrombolysis कहाँ करते हैं? Next, if I talk about submassive pulmonary embolism, that means the patient is having respiratory distress, but it is minimal and X-ray findings are not seen. Then in submassive pulmonary embolism, the drug of choice would be anticoagulants. Yes, the drug of choice would be, it can be low molecular weight heparin. The treatment of choice would be enoxaparin can be given, and fractionated heparin अगर नहीं option में तो ठीक है. So please remember, submassive में, but massive में thrombolysis, massive में no issues with this. ठीक है. Now please tell me, एक basic फंडा बता रहा हूँ, ठीक है, तो आगे देख लेंगे. ठीक है, ये याद हो गया सबको. pulmonary embolism कोई इशू नहीं है, pulmonary embolism में important है. There would be history of deep venous thrombosis or factor 5 reader mutation, and the patient will have prolonged immobilization. immobilization. ठीक है? Investigation of choice, CT angio, gold standard, pulmonary angio. I hope I am done. ECG finding, S1, Q3, T3. A patient after a road traffic accident sustains a fracture of shaft of femur. Now complains of respiratory distress, petechiae. Diagnosis is, so definitely if a patient comes to you after a road traffic accident and a long bone fracture. So if there is a long bone fracture, from the marrow, bone marrow, usually fat globules are released into circulation, and that can release cytokines which will damage pulmonary vessels. That causes respiratory distress. Okay? So after a shaft of femur fracture, respiratory distress is fat embolism syndrome. Fat embolism question have been asked on either pulmonary embolism or fat embolism. दोनों में से एक आता है, ऑर्थो या पल्मो में से. ठीक है? If I talk about the ECG, I can see bilateral diffuse infiltrates. What can be seen? What is seen on fat embolism syndrome X-ray? So bilateral diffuse infiltrates. Sometimes they are also referred to as snowstorm appearance. ठीक है, but not always. ठीक है? तो याद रखना. Fat embolism syndrome के लिए the diagnostic criteria is known as diagnostic criteria for fat embolism is third criteria. Major criteria याद रखना है तुम्हें. RCP. Major criteria is R for respiratory distress. C for CNS manifestation. C for so either the patient would be confused or the patient can be drowsy. Any of the CNS manifestations. And P for petechiae. P for so small bleeding spots. Minor criteria can be like fever. There would be fat globules in sputum or urine. Okay, all of these are minor criteria. Raised DSR, CRP, all of that. For diagnosis, 1 major and 4 minor are required. Diagnosis के लिए कितना होना चाहिए? So criteria for diagnosis of fat embolism syndrome is known as which criteria? How many major? How many minor? 3 major criteria are for sudden onset respiratory distress. C for CNS manifestation. C for and P for no issues with this. This is important. What is the investigation of choice for fat embolism syndrome? Investigation of choice for fat embolism syndrome. Anybody? Those who have joined online. ECT करोगे क्या करोगे? HRCT करोगे क्या? Those who are joined online, क्या हो गया? Urine or sputum analysis can be done, but it is first line investigation. It is not suggestive. Chest X-ray is again a first line investigation. HRCT test. Investigation of choice would be a HRCT test. Investigation of choice would be a ABG can be done. Again, it is a complementary investigation. HRCT chest. What is the treatment? Anybody? Treatment, definitely we will give supplemental oxygen. Treatment is what? Supplemental oxygen. No issues with this. Anybody? Fat embolism done. Moving further. So if a patient, अभी एक differential बताता हूँ जल्दी से. If a patient or long bone fracture comes to you with sudden onset respiratory distress within a period of 12 to 72 hours, this is diagnostic of fat embolism syndrome. If a patient of DVT comes to you after a prolonged immobilization with again sudden onset respiratory distress within a period of 24 to 72 hours, it is pulmonary embolism. It is pulmonary. But if a patient of H1N1 flu, that is swine flu, or H5N1 flu, that is avian flu, so after any pulmonary infection, if the patient comes to you with sudden onset respiratory distress and is admitted in ICU usually, then the classical case is of ARDS, that is acute respiratory distress. So sudden onset respiratory distress के 3 differentials. After long bone fracture, after DVT, after any flu or infection, Are there any fluor infection? If I talk about ARDS X-ray, so I can see almost both the lungs are white in color. So these are called as white out lungs. These are called as white out lungs. These are again bilateral diffuse pulmonary infiltrates are seen, right? This can also be termed as shock lung. This is also termed as, so this is the X-ray, and here you can see it is a CT picture, right? Both are showing diffuse bilateral pulmonary infiltrates, almost white lung ho jata hai, okay? So white out lung or shock lung, and COVID may be one of the complication of ARDS. And characteristic kya mention karte, which type of opacity? Which type of opacity? Which type of opacity? What is the main pathology in ARDS, guys? What is the main pathology in ARDS? That diffuse alveolar damage. What is the main pathology? What is the main pathology? So ARDS causes pulmonary edema. It damages the pulmonary alveoli as well as the endothelium, and therefore there is leaking of fluid into the pulmonary alveoli that causes pulmonary edema. But as it is not due to CHF, it is called as non-cardiogenic pulmonary edema. So non-cardiogenic pulmonary edema is caused by non-cardiogenic pulmonary edema is caused by non-cardiogenic pulmonary edema is caused by, and what is the main pathology? Diffuse alveolar damage. Which type of opacity? Ground glass opacity. Causes can be multiple. It can be a polytrauma patient. Okay, it can be a sepsis patient, DIC patient. Okay, any of these can be causes of ARDS. COVID-19 infection, flu infection, all of that. What is the treatment of choice? Anybody? Kya hua? What is the treatment of choice? High flow, low flow? Low flow oxygen. What is the treatment of choice? What is the treatment of choice? So 6 liters per minute के हिसाब से oxygen is given. Low flow. ठीक है? So what is the treatment of choice for ARDS? What is the treatment of choice for ARDS? Low flow oxygen. Apart from that, we can also try prone positioning, which improves ventilation. ठीक है? We can also try prone positioning, also given for COVID-19 patients. No issues with ARDS? याद रखो. Now, this is the case, guys. Yes, steroids can also be given definitely, but new edition of Harrison says it has not a very significant. It does not have a very significant role as such. It can be given. COVID में तो देखा. If I talk about this picture, here you can see one lung is normal, but the other lung is usually increased in size. That means there is hyperinflation. There is not a bilateral. Bilateral hyperinflation is seen in cases of bilateral emphysema. Bilateral hyperinflation. Bilateral hyperinflation, unilateral hyperinflation, pneumothorax. Unilateral hyperinflation, pneumothorax. So if I talk about the X-ray features of pneumothorax, important guys, please remember, here I will see a hyperinflation or increased blackening in one of the lungs. Along with that, I can see, here you can see any whitish marking of the bronchus or the vessels? No. So please remember, bronchovascular markings would be, bronchovascular markings are present in cases of emphysema. Along with that, I can see this kind of a picture. Okay? This is called as which sign? Deep sulcus sign. This is called as which sign? This is called as which sign? Deep sulcus sign. Suggestion of pneumothorax. Pneumothorax, as we discussed, it can be of two types. Either it is spontaneous pneumothorax or it is spontaneous pneumothorax is associated with emphysema. Spontaneous pneumothorax is associated with type 1 pneumothorax is due to emphysema. Type 1 pneumothorax is due to rupture of bleb in emphysema can cause spontaneous pneumothorax. Type 2, T for tension, T for trauma. So trauma can lead to emphysema can lead to. So pneumothorax ke liye I have given the mnemonic last time. It is ABC. Right? The mnemonic is ABC for symptoms. A for absent breath sounds. A for absent breath sound. And there will be absence of air entry. Absence of air entry. Absence of. So A for absent and absent air entry. B for breathlessness. B for so sudden onset breathlessness. And as it causes compression of the superior vena cava, therefore there will be congestion of the jugular vein. So C for congested neck vein. C for so no issues with pneumothorax. जल्दी से ABC रिवाइज करेंगे. A for absent and absent and absent air entry and absent. B for sudden onset and C for important. ठीक है. Wow. Now please remember spontaneous tension pneumothorax. What is the treatment of choice anybody in emergency? So please remember, if they ask you for first line management in cases of tension pneumothorax, the first line management would be inserting a wide bore needle. कहाँ पे? Needle insertion. Okay, needle insertion. Harrison still says second intercostal space mid clavicular line. अगर ATLS mention करते हैं, then only go to fifth intercostal space. ठीक है? तो medicine से question आ रहा है, prefer medicine. ठीक है? So needle insertion in the second intercostal space. Which line? Mid clavicular line. So needle insertion is done in which space? Needle insertion is done in which space? In which line? Whereas if they ask you the definitive management, then after, if the patient is admitted now and it is stable, now we will insert a ICD, that is intercostal drainage tube. So ICD is inserted in. ICD insertion is done in which line? Mid axillary line. Which line? So jaldi se needle insertion, which space? Which line? Definitive management के लिए ICD insertion, which space? Which line? Mid axillary line. ठीक है? Definitive management for both spontaneous as well as for tension, it is ICD insertion. But in cases of spontaneous, if they ask you first line management, you will try to give supplemental oxygen to the patient. Only if the patient has cyanosis, then you can insert needle. Otherwise, so इतना severe नहीं होता spontaneous. Therefore, will only give supplemental oxygen. ठीक है? No issues with pneumothorax now. I hope so. Next, a patient of pulmonary TB complains of respiratory distress. Chest X-ray is given. Diagnosis is. Wow. Shabash. So if there is any opacity in the lung field, that means there is accumulation of fluid. There is accumulation of fluid in the pleural cavity. This is called as pleural. So diagnosis is, and the risk factor is tuberculosis. So there is a tubercular pleural effusion in the patient, right? How to differentiate pleural effusion from hydropneumothorax? Shabash. In pleural effusion, we will have a curve. This is called as which sign? Anybody? Meniscus sign. Which sign? Which sign? Or which curve? Ellis curve. Which curve? So meniscus sign or Ellis curve are a feature of pleural effusion. Along with that, we can see blunting of which angle? Blunting of postophrenic angle. Blunting of which angle? Blunting of which angle? So if blunting is present, definitely it is effusion. And if there is a Ellis curve, that means it is a pleural effusion. But if in case we have a very horizontal line, blunting is present over here also, blunting of postophrenic angle, but we don't have a curve, rather a horizontal line, then the diagnosis is hydropneumothorax. By the name itself, it is evident. That means there is accumulation of water plus air. Okay? So horizontal line in, curve in, which curve, which sign. No issues with this. Now pleural effusion. Pleural effusion can be due to if the hydrostatic pressure is increased. Hydrostatic pressure is, or the oncotic pressure is. So if hydrostatic pressure increases in cases of congestive heart failure, it increases in cases of congestive heart failure, right? Whereas oncotic pressure decreases because there is loss of proteins. It can be seen in conditions like cirrhosis or nephrotic, cirrhosis and nephrotic syndrome and समझ में आ गया फंडा pleural effusion का. Now pleural effusion can be of two types, guys. Pleural effusion can either be transudative. Transudative means दोनों आउटसाइड ही है। Transudative means non-inflammatory. Transudative means, whereas exudative means inflammatory. ठीक है? For differentiation we have which criteria? Guys, criteria ये पूछा गया है recently. ठीक है? So the first feature that will check in Wright's criteria would be pleural fluid protein. Pleural fluid protein should be more than 0.5 than the serum protein. So pleural fluid protein is more than 0.5 times the serum protein is called as exudative variety. It will be called as, so अगर ज़्यादा protein है, it is definitely due to inflammation. That is exudative variety. Next, then pleural fluid LDH. Pleural fluid more than 0.6 times. More than 0.6 times the serum LDH. More than 0.6 times the serum. Again LDH ज़्यादा है, inflammatory exudative variety. Next one और important feature है वो एक ही है, nothing different. So pleural fluid LDH level, if it is more than 2 times the upper reference limit of serum LDH. More than 2 times the upper reference limit of serum LDH. तो ये इतना सा याद रख लो यार, that's important. Pleural fluid protein more than 0.5 times. Pleural fluid protein more than 0.5 times. Pleural fluid LDH more than 0.6 times. Pleural fluid LDH more than 0.6 times. Pleural fluid LDH more than 2 times the upper reference limit. Pleural fluid LDH more than 2 times the upper reference limit. ठीक है? Exudative variety can either be unilateral or bilateral, but transudative variety is always and always. Pressure increase होगा तो ऐसा है क्या एक लाइन में होगा दूसरे में नहीं होगा. Please remember transudative variety is always, so CHF is always bilateral pleural effusion. Okay, transudative is always समझ गए. तो अगर bilateral दिख रहा है think in terms of CHF more commonly. ठीक है, याद रखना most common cause of transudative pleural effusion है, most common cause of transudative pleural effusion है, but most common cause of exudative pleural effusion can be infections like TB. Second is malignancy. And third is pneumonia. Third is no issues with this, I hope. Infections will lead to exudative. Infections will lead to malignancy. Will lead to malignancy, infection, inflammation, all exudative. Only CHF transudative. ठीक है. Cirrhosis भी transudative, nephrotic syndrome भी usually transudative. ठीक है. No issues. Treatment of choice बताओ जल्दी से. Investigation of choice definitely first line X-ray. Investigation of choice is a HRCT chest. Treatment of choice. ICD डाल सकते हो, उसको क्या बोला जाता है? Thoracocentesis. Treatment of choice है. So we'll insert a needle or a tube and drain the fluid. ठीक है. So treatment of choice है. पहले ये क्वेश्चन आता था. Now please remember which view of X-ray would be preferred. Which view? If it is minimal pleural effusion, we will prefer lateral decubitus view. If it is minimal pleural effusion, we will prefer. So this was the question. A person is having minimal pleural effusion. View of X-ray preferred is lateral decubitus view. View of X-ray preferred is. ठीक है. So HRCT chest is preferred, followed by ultrasound. ठीक है. And if it is minimal pleural effusion, one of the investigations can be chest X-ray, but in which view? Lateral decubitus view. अगर minimal है, it is only seen on lateral X-ray. ठीक है. No issues with this. And अगर thoracocentesis, after even doing thoracocentesis, pleural effusion is recurrent, then we can inject a sclerosing agent in the pleural cavity. This treatment is called as pleurodesis. Which is usually done in cases of malignant pleural effusion. 5-year-old child presents with low-grade fever, cough, night sweats, and chronic weight loss. Diagnosis is 5-year-old child, low-grade fever, cough, night sweats. Classical symptoms of TB, classical symptoms of tuberculosis, right? So low-grade fever, this will usually rise in Evening. So evening rising fever or diurnal variation of fever, cough, productive cough for more than 2 weeks, night sweat, anorexia and chronic weight loss are all suggestive of tuberculosis. Rather, these are constitutional symptoms of TB in the patient. Most common site for primary TB. Most common site for primary TB. Lungs. Most common site of primary TB. Lungs में कहाँ पे? Gone's focus is seen where? Lower part of upper lobe. Lower part of. Here we can find. So this is a Gone's focus which can be seen. Okay? No issues with this. So this is the Gone's focus which can be seen. Okay. After Gone's focus, what can happen if the patient has good immunity? Then there would also be involvement of lymph nodes. Okay. There would also be involvement of lymph nodes, and there can even be lymphangitis. So if there is Gone's focus, lymphadenopathy and lymphangitis. Gone's focus, lymphadenopathy and lymphangitis. It is known as which complex? It is called as which complex? Gone's complex. And if the patient has good immunity, then there would be calcification of this Gone's complex. And calcification of Gone's complex would be called as Ranke's complex. Calcification of Gone's complex is called as most common site for secondary TB या extrapulmonary TB बता दो. Most common site for extrapulmonary TB. Most common site for extrapulmonary TB are followed by pleura. Followed by, no issues with this. Most common site for extrapulmonary TB. Followed by gut, followed by genitourinary, gut, GIT, and then bones. Okay, no issues with this. Bones mein most common site affected is spine, which will cause Pott's spine, D12. Okay, no issues with this. Now, what is the investigation of choice for TB? Screening test can definitely be a sputum smear examination or a chest X-ray in the patient. Investigation of choice is a TB NAT. Investigation of choice is a TB NAT. Or sometimes we can prefer gene expert. Okay? So either of them can be preferred. If it is a lymph node TB, then it should be biopsy or FNS. Lymph node TB may will prefer. Pleural TB may will prefer. Pleural fluid CB NAT, pleural fluid gene expert. Right now, pleural biopsy. CB NAT would be done, but not on the pleural fluid. It would be done on the pleural biopsy. So investigation of choice for pleural TB. तो यही सिले मिस्टेक्स होता है. हम pleural fluid CB NAT कर देंगे. It is not pleural fluid CB NAT. It is pleural biopsy CB NAT. ठीक है? We'll take the tissue from there. And in cases of TB, wherever it will cause ascites, pleural effusion, there would be elevated levels of one enzyme, and that is called as. This is characteristic. Adenosine deaminase levels are increased. In TB, which levels are increased? Adenosine deaminase levels are increased. No issues with this. Treatment of choice for TB is ATTT. Treatment of choice is ATTT, right? ATTT. How many months of intensive phase? 2 months of intensive phase. And how many months of continuation phase? Total 2 months के लिए we will give. 2 months के लिए we will give. And 4 months के लिए we will give. Pyrazinamide is withdrawn because it causes hepatotoxicity. Pyrazinamide is withdrawn because it causes. H for isoniazid, R for Z for pyrazinamide, E for and S होता है वो injectable streptomycin. So if they ask you only injectable first line anti-tubercular drug, answer is streptomycin. ठीक है? Please remember, in cases of extrapulmonary TB, the treatment duration increases for. It will increase for. Usually, it can range from 6 to 9 months. Okay, it can range from 6 to 9 months. Okay, important. Now, most common site for congenital TB बता दो. Most common site for congenital TB. Most common site for congenital TB. Okay, most common site for congenital TB is liver. Okay, no issues with this. Now talking about tumare drugs. These has been questions which has been asked. If a person has resistance to isoniazid or rifampicin, then it is called as MDR TB. Isoniazid or rifampicin resistant is called as multi-drug resistant TB. Whereas यहाँ पे लिख देता हूँ, ठीक है? XDR TB कब बोलेंगे? Extensively, it is extensive, not extreme. Extensively drug resistant TB. When there is resistance to isoniazid or plus fluoroquinolone plus second line injectable plus second line drugs like amikacin, capreomycin, all of that. ठीक है? No issues with the streptomycin नहीं. ठीक है? amikacin, capreomycin, kanamycin. ठीक है? So ये समझ गए? TDR means that TB is not responding to any of the available drugs of in the market. ठीक है? XDR TB में the new drug which is used is bedaquiline. It is bedaquiline or sometimes delamanet. Question पूछा गया इसलिए बताया. Here you can see again a TB patient but having these kind of a X-ray. What kind is seen? Which appearance is seen? Small reticulonodular opacity is known as. So snowstorm appearance is seen in which TB? Snowstorm appearance is seen in miliary TB. Then with TB, no issues with TB. Anybody? Moving further. यहाँ पे the patient is having opacity in the which lobe? Upper lobe दिख रहा है ना? Middle lobe. It is middle lobe. So opacity in the middle lobe. Okay, it is due to consolidation. Consolidation is due to accumulation of fluid inside the lungs. ठीक है? And consolidation is a feature of pneumonia. Acute infection in lungs is called as pneumonia. And the most important hallmark feature is consolidation. Hallmark feature is it can either be a lobar pneumonia as seen in this case. Here only one lobe is involved, therefore it is called as a lobar. Extremely nahi, extensively. Please remember this mistake most of the people did last time. It is extensively drug resistant TB. So if one lobe is involved, it is called as lobar pneumonia. But if a round opacity is seen, it is called as round pneumonia. If a round opacity is seen, it is called as round pneumonia. Can anybody tell me most common cause of pneumonia overall? Most common cause of pneumonia is Streptococcus pneumonia, also known as pneumococcus. Most common cause of community acquired pneumonia, Streptococcus pneumonia. Most common cause of community acquired pneumonia, most common cause of lobar pneumonia, most common cause of lobar pneumonia, most common cause of round pneumonia, Streptococcus pneumonia. Answer change nahi karna. If they ask you most common cause of hospital acquired pneumonia, so hospital acquired means after patient admission, the patient develops symptoms of pneumonia within 48 hours. So most common cause of hospital acquired pneumonia, most common cause of hospital acquired pneumonia, most common cause of ventilator associated pneumonia, most common cause of ventilator associated pneumonia, Pseudomonas aeruginosa followed by Acinetobacter. No issues with this. Now, sorry. Most common cause of pneumonia in alcoholic patient. मैंने क्या बोला? Most common cause of alcoholic pneumonia, most common cause of pneumonia in alcoholic patient. क्यों alcohol पीने वाला इंसान नहीं है? Again, it is Streptococcus pneumonia. Most common cause of pneumonia in alcoholic patient is Streptococcus pneumonia. यही खेलते हैं guys. And this is the place where you need to pay attention. Most common cause of pneumonia in alcoholic is Streptococcus pneumonia. But if I say, if an alcoholic patient presents to me with anybody red currant jelly sputum, red currant, which type of sputum? Which type of sputum? Along with that, on chest X-ray, if I find which sign? Bulging fissure sign. Which sign? Which sign? Then the cause would be. Then the most common cause would be Klebsiella pneumonia. Then the most common cause is Klebsiella. So which type of sputum is seen in Klebsiella pneumonia? And which sign is seen on chest X-ray? No issues with this. Now, if I ask you, most common cause of pneumonia in patients of COPD. Haemophilus influenzae type B. So, commoner cause of pneumonia in COPD patient is common cause of COPD patients having pneumonia is HIV. This was a question. ठीक है, मैं बस question important पढ़ा रहा हूँ. अगर नहीं पढ़े हुए तो पढ़ लो because ये previous year questions है. That means you are actually losing on something. Most common cause in COPD patient for pneumonia is HIV, Haemophilus influenza type B. ठीक है. Next, most common cause for pneumonia in HIV patients. HIV patient इंसान नहीं है. Most common cause of pneumonia in HIV patient is strep pneumonia. But if I say the CD4 count of this patient is less than 200, then the most common cause becomes Pneumocystis carinii or Pneumocystis jirovecii pneumonia. If CD4 count below 200, Pneumocystis. If CD4 count below 200, Pneumocystis. Otherwise most common. Now, if I talk about typical pneumonia and atypical pneumonia, which would be severe clinically? Typical pneumonia is severe clinically. Okay, and chest X-ray will show us consolidation. Whereas atypical pneumonia is also called as which type of pneumonia? Anybody? Atypical pneumonia is also called as walking pneumonia, because the patient does not have clinical symptoms, asymptomatic hota hai, but the chest X-ray will be very dirty. Okay, the chest X-ray would be very dirty in this patient. Okay, so please remember the chest X-ray will show us significant changes. No issues with this. So if the patient is having less symptoms but chest X-ray showing significant changes, you will think in terms of atypical or walking pneumonia. Most common cause of atypical pneumonia, Mycoplasma pneumonia. Most common cause of atypical pneumonia. Okay, atypical pneumonia definitely can be caused if it is associated with diarrhea or AC exposure. It is caused by Legionella pneumophila. Okay, it can also be caused by Pneumocystis jirovecii. So Pneumocystis jirovecii causes which type of pneumonia? Atypical pneumonia. Whereas viral infections, Klebsiella, one of the causes. Viral infections like measles, influenza, all of them will cause atypical pneumonia. No issues with this. Pneumocystis jirovecii mein, the patient's X-ray will show us. Pneumocystis jirovecii ka patient X-ray will show us. So ye important hai. If a patient in HIV is showing some chest X-ray changes, the cause is Streptococcus pneumonia. But if the patient of HIV having pneumonia is not showing any chest X-ray changes, the cause is Pneumocystis jirovecii. So Pneumocystis jirovecii mein chest X-ray, याद हो गया, याद रखना is important. Then which is the score for Pneumocystis jirovecii pneumonia? Curve 65. Sorry, Pneumocystis nahi, for all types of pneumonia the score is curve. The criteria is known as curve. C for confusion, C for U for blood urea nitrogen, U for if it is elevated, R for respiratory rate, if it is more than 30, okay, tachypnea. Then B for blood pressure, low blood pressure. T for low blood pressure. Okay, low blood pressure less than 90/60, and 65 means the patient of more than equal to 65 years. Patient more than equal to, all has 1 point, so total are 5 points with us. If a patient has a score of 0, he should be treated on. If a patient has a score of 0, he should be treated on OPD basis. If a patient has 1 to 2, he should be treated on IPD, inpatient department. If a patient has score of 1 to 2, he should be treated on. And if a patient has score more than equal to 3, IPD. More than equal to 3, 1 to 2, IPD. 1 to 2, 0. What is the drug of choice? Anybody? Drug of choice is macrolides. So one drug which is active against Pneumocystis, Streptococcus pneumoniae as well as Mycoplasma. So किसी भी type का होने दो, it can treat is azithromycin. So if they ask you the single word from macrolide, answer should be. They ask you single word from macrolide, answer should be. For Pseudomonas, we can add meropenem. For Pseudomonas, we can add meropenem to the picture. Any meropenem can be added. Okay, yeah. No issues with this. Anybody? I hope pneumonia is done. A patient of cystic fibrosis now presents with bronchoria. Bronchoria is also seen in chronic bronchitis, but here, along with bronchoria, the patient will also have a productive cough along with foul-smelling sputum. Productive cough along with foul-smelling sputum or halitosis. And there is dyspnea. What is this feature, anybody? So clubbing is also seen. What is the diagnosis? Diagnosis is bronchitis. And bronchiectasis is due to irreversible or reversible damage? It is due to irreversible damage of lower or upper airway? Irreversible damage and dilatation of? Irreversible damage and dilatation of? Upper airway. समझिए मतलब bronchus and primary bronchioles are involved. ठीक है? No issues with this bronchiectasis. Now bronchiectasis can have multiple causes. When there is a foreign body aspiration in the patient, okay? When there is an infection like pneumonia in the patient, or the patient is immunocompromised, or the patient may be having a genetic condition like Carter-Jenner syndrome, cystic fibrosis. So all of these are risk factors for bronchiectasis. The patient will have recurrent infection. The patient will have recurrent, and that causes bronchoria, productive cough, and foul-smelling sputum in the patient. ठीक है? Pus would be filled in the lungs. ठीक है? तो ये characteristic case है तुम्हारा bronchiectasis का. Sorry. So bronchiectasis में all of these features are seen. If I talk about the investigation, right now, I hope all of you know, the symptoms: dyspnea, bronchoria, productive cough, foul-smelling sputum, all of that. Along with that, the first line investigation is definitely a chest X-ray. On that, I can find the most common subtype of bronchiectasis, and that is most common subtype of bronchiectasis is cylindrical. Most common subtype of bronchiectasis is emphysema की subtype रह गया क्या? Emphysema का most common subtype is most common of emphysema. Most common subtype in emphysema centriacinal. Most common subtype in emphysema. Most common subtype in emphysema. Most common subtype associated with smoking in emphysema. Again centriacinal. Most common subtype in emphysema which is associated with smoking. Most common type of emphysema which is associated with alpha-1 antitrypsin deficiency. Then the answer would be pan-acinal. Alpha-1 antitrypsin deficiency can also be a risk factor for bronchiectasis. It can also be a risk factor for bronchiectasis. Again, it is a genetic condition. Most common. Clinically, it is usually pan-acinal, but usually they try to ask about the books only. So in books, usually the most common is centriacinal, and alpha-1 antitrypsin it is pan-acinal. ठीक है, वो याद रखिए. If I talk about this chest X-ray finding, most common subtype is cylindrical. It will give which appearance on chest X-ray? It will give a tram-track appearance. Which appearance is seen on chest X-ray? Which appearance is seen on chest X-ray? Here also on CT you can see a tram-track appearance. Here also on CT you can see a tram-track appearance. If this kind of appearance is seen, it is called as the signet ring sign. It is called as the signet ring sign. And if multiple grape-like vacuoles are seen, this is called as the honeycombing pattern or tree bud appearance or honeycomb pattern. Tree bud or honeycomb or, but tree bud is not very much specific to bronchiectasis, therefore it is not considered a specific site. The most common is tram-track appearance because the most common subtype is cylindrical. If I talk about cystic fibrosis, please tell me what is the gene mutation in cystic fibrosis? It is the CFTR gene mutation. Which gene mutation? F508 भी आ सकता है कभी ऑप्शन में. Which channel? F508. Which one? And which chromosome is affected? Chromosome number. So in cystic fibrosis there will be mucoviscosis. That means all the secretions will become thicker. Therefore, the patient can have bronchiectasis in lungs, The patient can have malabsorption syndrome due to thickened pancreatic secretion. Okay, all of this can be seen in cases of cystic fibrosis. Cystic fibrosis mein we can give mucolytics to the patient along with chest physiotherapy. Okay? And in cystic fibrosis, the classical case, mother is kissing her baby, but the skin tastes salty. The skin would be because it contains high amount of chloride. It contains high amount of sweat chloride. It contains high amount of so sweat में chloride ज़्यादा होता है, इसलिए the skin tastes salty. This was a classical case of cystic fibrosis in the patient. No issues with this, anybody? If I talk about one more association of bronchiectasis, that is known as Carter-Jenner syndrome, is due to defect in which protein? It is due to defective dyning protein. Defective dyning protein. What is the triad of Carter-Jenner syndrome? RBR. So R goes for recurrent sinusitis. R goes for B goes for and I goes for inversus. I goes for situs inversus. I goes for which is right-sided heart. That is called as dextrocardia. Okay, so triad of Carter-Jenner syndrome. Please say R for, B for, I for. Infertility is not a part of the triad. Infertility is only seen in males, therefore it is not a part of the triad. Male infertility is seen. Which type of infertility? Male infertility is only seen in cases, right? So it is not a part of triad. Now, what is the treatment of choice for bronchiectasis? Anybody? Investigation of choice, बताओ जल्दी. ये क्या दिख रहा है? HRCT chest. Investigation of choice is a investigation of choice for bronchiectasis. Investigation of choice for bronchiectasis. Treatment of choice would be, we can definitely give antibiotics for 14 days along with mucolytics would be given in chest physiotherapy. Chest physiotherapy. ये important ये भूल जाते हो. So chest physiotherapy is one of the first line management of bronchiectasis, which will free the mucus. ठीक है? So antibiotics plus chest physiotherapy. Next. A patient was working in sandblasting industry for 20 years and now presents with dyspnea and cough. Chest X-ray is given, diagnosis. So if they are mentioning about any profession, definitely they are talking about some occupational disease. Sorry guys. Occupational lung diseases are called as and pneumoconiosis are obstructive lung diseases or restrictive lung diseases. They are restrictive lung disease. Pneumoconiosis are so dust fibers will damage your lungs. Okay, the dust fibers will damage your lungs, and there will be interstitial fibrosis. Okay, no issues with this. Important. Please remember. So, what is the characteristic feature of restrictive lung disease or pneumoconiosis? Interstitial. What is the characteristic feature? Interstitial में fibrosis हो जाता है. ठीक है? That is why the compliance decreases and therefore it is RLD. Now, most common pneumoconiosis. Anybody? Most common pneumoconiosis is and silicosis is associated with which industry? Sandblasting industry. It is associated with also associated with glass industry. Also associated with and last time December में question था stone breaking या rock breaking industry. पता नहीं क्या है. Okay. So it is also associated with stone breaking या rock breaking industry. Again same thing sandblasting. ठीक है. Cement exposure से हो सकता है, but due to cement exposure, asbestosis is much more common. ठीक है. What is the most pathogenic size of fibers? Most pathogenic size of fibers is 1 to 5 micron. Most pathogenic size of fibers is 1 to 5 micron. ठीक है. Here definitely the patient is working in a sandblasting industry for 20 years. Now presents with dyspnea and cough. The lung will show definitely on biopsy interstitial fibrosis. And if I check for the chest X-ray, I will get these small reticulonodular opacities. Which type of opacities? And these reticulonodular opacities are called as which appearance? Sharp. It is called as the most common appearance is seen in which pneumoconiosis? Snowstorm appearance is seen in which pneumoconiosis? Silicosis. Okay, important. And in which TB? Which TB? Okay. Along with that, definitely we will also find a calcification that is called as eggshell calcification. Which calcification? Which calcification? Eggshell calcification. Silicosis, please remember, please tell me, silicosis is most commonly associated with which disease? Most commonly associated with silicosis is most commonly associated with tuberculosis. Therefore, it is termed as silicotuberculosis in the patient. Next, if I say my patient was working in a cement industry or is a construction worker, the patient is more likely to develop asbestos. All the pneumoconiosis will be more common in which lobes? Upper lobe. All pneumoconiosis are more common in except for asbestosis, which is more common in important. In asbestosis, please remember the most pathogenic fiber is straight fiber, also called as amphosite fiber. Most pathogenic fiber of asbestosis. ये सब वन लाइनर क्वेश्चन से जो आ चुके हैं. Amphosite fibers are most pathogenic fibers of asbestos. On biopsy, definitely I'll find again interstitial fibrosis, but I can also see a very characteristic body. These are called as asbestos bodies or ferruginous bodies. Asbestos bodies or so these are asbestos fibers loaded with iron. Okay? So on biopsy, which bodies are seen? Asbestos or ferruginous body. What is the most pathognomic feature? If they ask you, most pathognomic feature of asbestos? Pleural calcification of pleural plaques. Most pathognomic feature of asbestos is pleural calcification. Right? If they ask you the most common tumor associated with asbestos, most common tumor associated with asbestos is but the most specific tumor associated with asbestos is mesothelioma. Mesothelioma means it is a pleura-based tumor which arises from the pleural cavity. No issues with this. So याद रखना, most common is, most specific is mesothelioma. ये questions आ चुके हैं बार-बार. Sorry. Okay. Now again, a patient, again industry worker. But sorry, this time he is an industry worker working in cotton mill industry or textile industry. The patient will be exposed to cotton dust, and he will complain of Monday chest tightness. He will complain of, what is the diagnosis? Bicyanosis. What is the diagnosis? Cotton dust exposure. Bicyanosis. याद रखना. Whereas if I talk about a sugar mill worker, who is exposed to bagasse or molasses, okay, he would be having bagasosis. So sugar mill worker is responsible for having. Sugar mill worker is at a risk of having which industry? Cardboard industry में भी हो सकता है. So sugar mill or cardboard or which type of pneumoconiosis? Or bagasosis. Which organism is responsible? PSM. Which organism is responsible? Thermophilus actinomycetes. Which organism? या organism का नाम पूछा गया. So which organism is responsible for bagasosis? Which organism is responsible for farmer's lung? So farmer's lung is also one of the type of pneumoconiosis. It is caused due to moldy hay exposure. It is again Thermophilus actinomycetes. For farmer's lung also the organism is Thermophilus actinomycetes. Aspergillus जो तुम बोल रहे हो, Aspergillus fumigatus causes ABPA. Aspergillus fumigatus causes allergic bronchopulmonary aspergilloma. Okay, Aspergillus fumigatus causes allergic bronchopulmonary aspergilloma. which is more commonly seen in bronchial asthmatic patient. ठीक है? So if a bronchial asthmatic patient comes to you with black or brown sputum plugs, mucormycosis नहीं होगा वो. ठीक है? Bronchial asthma patient coming to you with black or brown sputum plugs, answer should be ABPA, allergic bronchopulmonary aspergilloma, caused by Aspergillus fumigatus. ठीक है? No issues with that. All of these pneumoconiosis are which type of hypersensitivity, anybody? They are type 4 because they are a group of hypersensitivity pneumonitis, and it is type 4 hypersensitivity. Which type of hypersensitivity? Type 4 hypersensitivity. No issues with this, anybody? Last, lung tumors. उसके बाद चलो छोड़ दूंगा. Lung tumors की अगर मैं बात करूं, please tell me the most common lung tumors would be sorry. Most common lung tumors are most common lung tumor is most common lung tumor is or most common lung malignancy is metastasis. Most common lung malignancy, most common lung tumor, metastasis or secondary. ठीक है? If I ask you about primary lung tumor, so most common primary benign lung tumor. अब बोलो most common primary benign lung tumor in adult, answer is hamartoma. Most common primary benign lung tumor in adult, most common primary benign lung tumor in adult, most common primary benign lung tumor in children, inflammatory myofibroblastic tumor. Inflammatory myofibroblastic tumor. So inflammatory myofibroblastic tumor has which tumor marker? ALK. Which tumor marker? Which tumor marker? If I ask you the most common lung malignancy now, most common primary lung malignancy, चलो फिर बोलोगे. The answer would be adenocarcinoma. Most common lung malignancy. Most common lung malignancy. Most common lung malignancy in non-smokers. Most common lung malignancy in females, but most common lung malignancy in smokers, squamous cell carcinoma. Because in smokers we will have squamous metaplasia. ठीक है? Most common type of metaplasia is squamous or columnar. GID के patient ज़्यादा है या smokers ज़्यादा है? Smokers ज़्यादा, right? So squamous metaplasia is most common. ठीक है? याद रखना. So adenocarcinoma, if I talk about, adenocarcinoma is central or peripheral in location. It is usually peripheral in location. Adenocarcinoma is ये differentiate करने में मदद करता है which type of lung tumor it is. X-ray देंगे और peripheral mass होगा, so it is usually adenocarcinoma. Please remember this. ठीक है? And adenocarcinoma, the best tumor marker would be, so definitely on biopsy we will find if it is adenocarcinoma arising from columnar epithelium. So we will find atypical or abnormal glands. But the best tumor marker would be anybody? क्या? Sorry. क्या? Best tumor marker? आपसे नहीं. Best tumor marker for adenocarcinoma? Best tumor marker for adenocarcinoma? TTF1 can also be one of them. But the best one is napsin A. Now, one variety of adenocarcinoma, guys. Please remember here, you can see. I hope malignancy का सबको पता है. Important funda है. On H&E staining, the cytoplasm will stain pink or eosinophilic, whereas the nucleus will stain blue or basophilic. But in malignant cells, what happens? The nucleus size increases. Malignant cells में nucleus size increases. High N/C ratio. This was one of the options. ठीक है? So if the nucleus size increases, the cell will appear blue almost. Okay? The cell will almost appear blue or basophilic. The malignant cells will appear blue. And here you can see these blue color cells are only growing along the mucosa. These are only growing along the mucosa. They are not invading the inner layer. If a cancer is not invading the inner layer and only growing along the mucosa, this is called as which type of growth? A tumor growing only along the mucosa and not invading the inner layer. It is called as which type of growth? It is called as lipidic growth. It is called as which type of growth? Which type of growth? Also known as which pattern? Butterfly on fence pattern. Butterfly on. So lipidic growth or butterfly on fence pattern is suggestive of which type of tumor? adenocarcinoma, but in C2. Why? Because it is not invading the basement membrane. So if there is a lipidic growth or butterfly fence pattern, it is suggestive of adenocarcinoma in C2. Previous name was bronchoalveolar carcinoma. Okay, no issues with this. Now, if I talk about a smoker patient coming to me, right, the most common lung cancer would be squamous cell carcinoma. Most common lung cancer would be, and on squamous cell carcinoma biopsy, I will find these kind of whorled bodies. These are called as cytokeratin pearls. These are called as, so cytokeratin pearls are a feature of, cytokeratin pearls are a feature of, cytokeratin pearls are a feature of तमाम bodies मत समझना इनको, ठीक है, हिस्ट्री देख लो पहले. अगर lung cancer दिया है and these type of bodies are seen, these are called as cytokeratin pearls, and it is a feature of which type of carcinoma? Squamous cell carcinoma. Important. Which is the best tumor marker for squamous cell carcinoma? Anybody? So universal tumor marker for carcinoma, cytokeratin. Universal tumor marker for all carcinoma, cytokeratin. But the best tumor marker for squamous cell carcinoma, P40 and P63 and P63 and it is the best tumor marker for which carcinoma? Squamous cell carcinoma is where location? Central or peripheral? So squamous cell carcinoma would be the other type of carcinoma which is also associated with smoking. It is also central in location. And here you can see on biopsy multiple small basophilic cells are seen. Okay, very small cells. Therefore, it is called as small cell carcinoma. Therefore, the diagnosis becomes small cell carcinoma. If they ask you most common lung malignancy associated with smoking, most common squamous, but most strongly associated with smoking, small cell. Most strongly associated with smoking, small cell carcinoma. Okay? In small cell carcinoma, multiple small cells would be seen, and the chromatin would be salt and pepper chromatin. Which type of chromatin? Best tumor marker for squamous small cell carcinoma. So it is a neuroendocrine tumor, right? Neuroendocrine tumor. Best tumor marker would be domogranin. Best tumor marker is others can be synaptophysin or neuron specific. Okay? Now here I am having a tumor which is involving the lung apex. Okay, lung apex को involve करने वाला superior sulcus tumor is called as and it will compress the cervical sympathetic chain. As it compresses the cervical sympathetic chain, it can lead to which syndrome? It can cause which syndrome? Honor syndrome is remembered by perfect meal. It is remembered by P for process, P for M for meiosis, M for E for enophthalmos, E for anhydrosis, A for and L for loss of stereospinal reflex, L for. So if these features are seen in a lung cancer, it is more likely to be which kind of tumor? Pan-post tumor. Now if I talk about paraneoplastic syndromes, guys, most common paraneoplastic syndrome associated with squamous cell carcinoma is hypercalcemia. Most common associated with squamous cell carcinoma is but the most common lung malignancy associated with paraneoplastic syndromes would be small cell carcinoma. याद रखना, most common paraneoplastic syndrome seen with squamous cell carcinoma is hypercalcemia, and it is due to the parathormone related peptide which is produced by the cancer cells. ठीक है? But if they ask you the most common lung malignancy which is associated with paraneoplastic syndrome, सबसे ज्यादा paraneoplastic syndrome कौन सी lung malignancy cause करेगी? Answer should be small cell carcinoma. Answer should be small cell carcinoma. It can lead to ectopic ACTH production, which will cause Cushing syndrome, which will cause. It can lead to ectopic ADH production, which will cause syndrome of inappropriate ADH secretion, SIADH. It can lead to production of autoantibodies which are attacking the presynaptic calcium channels, and therefore it can cause which syndrome? Which syndrome? Lambert-Eaton syndrome. No issues with this. If I talk about the treatment, for all lung cancers or lung malignancies, it would be surgical excision. It would be surgical excision, except for small cell carcinoma, except for it is treated with chemoradiation. The treatment of choice for small cell is chemoradiation. Yaad rakhna. Which lung malignancy has worst prognosis among all? Which lung malignancy has the worst prognosis among all? If I talk about lung metastasis, okay, lung metastasis will be like, it is called as cannonball metastasis. Lung metastasis is so this kind of features would be seen. Okay, the cannonball metastasis, and it is usually due to a choriocarcinoma, that is a placental site tumor. Okay, if I talk about metastasis from lung malignancy, if a patient is having any lung cancer and metastasis from lung cancer, the most common site would be, now from lung malignancy, the cancer cells are spreading to other organs. Then the most common site of metastasis is lung malignancy, followed by, but in brain usually, which cancer causes metastasis? Small cell carcinoma, and therefore it has the worst prognosis among all. ठीक है, फंडा याद रखो, इजी हो जाएगा. ठीक है, इसके अलावा और कुछ याद तो नहीं रखना है. लास्ट वन, pulmonary hematoma, the most common primary benign tumor in adults. Which calcification is seen? Popcorn calcification on chest X-ray. Popcorn calcification on chest X-ray. Popcorn calcification on chest X-ray. Popcorn calcification on mammography. Popcorn calcification on mammography. Fibroadenoma breast, benign tumor of breast. ठीक है. Whereas popcorn cells are seen in, popcorn cells also termed as LH cells. Popcorn cells or LH cells are usually seen in cases of, मैंने पढ़ा है ना, it is seen in cases of nodular lymphocytic predominant Hodgkin's lymphoma, which is also called as atypical Hodgkin's lymphoma. So popcorn cells are seen in nodular lymphocytic predominant Hodgkin's lymphoma. Popcorn cells are a feature of nodular lymphocytic predominant Hodgkin's lymphoma or typical Hodgkin's lymphoma. Whereas in cases of typical Hodgkin's, we can see with cells are S cells, that is your Reed-Sternberg cells. No issues with this. I'm sorry I could not cover the other session, that is rheumatology today, but I hope you are fine with it. कोई दिक्कत नहीं है. At least we have covered pulmo in great details, because I told you pulmo is important. घर जाके अच्छे से pulmo पढ़ लेना please. The next time we'll cover rheumatology, and the next session I will inform you. ठीक है? एक बात बता दो, after integrated session, do you want one session for general path and general pharma, या फिर I can take up other subject? General path and general pharma का एक session? ठीक है, चलो. After we complete this, we'll start with general path and general pharma, one session, that's it. Thank you so much.